Once again, I'm back here to talk about some miscellaneous things that I think are important, but nonetheless miscellaneous. And so today, or for this one, we're going to focus on contrast, specifically contrast nephropathy, how to predict the risk and how to help mitigate them. It's funny, I talked about this. I'm sure all of us have had to deal with the contrast shortage earlier this summer, which is still going on for some of us. And so once again, this is an evolving case. It starts on Friday in clinic. Once again, another add-on case, a second opinion for possible elective PCI, high yield for procedure. Of course, I'll see this extra patient. So 76-year-old person, once again, diabetic, hypertensive. So in this case, this person has chronic kidney disease and has exertional angina. Baseline GFR is around 45. He had an abnormal nuclear stress test, as well as an angiogram, an outside institution, several days prior, showing 2 lesions, RCA, OM1, straightforward lesions that are both suitable for PCI. However, given his renal dysfunction, they stopped the procedure, and the patient is here for additional consultation. And so he's very concerned, rightfully so, about his renal dysfunction and the possibility that contrast dye can cause acute issues, possibly chronic, but mainly acute issues, because he's been reading online. It can occur. You explain to him it's not 100%, and there are some strategies that you can use to help reduce this. And so, first of all, the patient wants to know what his risks are of acute kidney injury. And so he's 76, he's diabetic, he's hypertensive, his GFR is around 45. And so what would you quote him as his risk for possibly developing contrast-induced nephropathy for a routine, quote, routine case? So your choice is 8%, 14%, 25%, or 50%. So let's see here. What would you quote this gentleman? %, risk is what the majority of people would quote, with the other 2 groups around 14 to 25%. Let's start with some definitions here. There's an absolute criteria, which is an increase in serum creatinine of more than 0.5 milligrams per deciliter. And there's also a relative increase, so that's an increase in the serum creatinine of greater than 25%, and/or, which they're related, a decrease in the GFR of greater than 25%. So both an absolute and a relative definition. Contrast, once again, somewhat debatable, not completely known, but it's hypothesized that there could be either direct or indirect effects, whether it be from toxicity, from free radicals, or the osmolarity of the agent used. Once again, hypothetical, not necessarily shown to necessarily be true in all cases. The timing seems to start around a day or 2 after the procedure, peaks around 3 to 7 days, and hopefully in most cases normalizes after 7 to 10 days. Now, what we do know, there are risk factors, both patient and procedural risk factors that are involved. And so particularly in this specific case, when you're talking to a patient beforehand, it's nice to know which factors increase it. And these are, most of them pretty much, I think, intuitive. The lower the creatinine, diabetes, low ejection fraction, low output, a situation, acute in the setting of cardiogenic shock, obviously higher risk, and also in the setting of other nephrotoxic drugs. Procedural issues, contrast volume, osmolarity of contrast, put a question mark there. Type of contrast, also in terms of viscosity, also put a question there. Multiple exposures of contrast media in a short period of time, i.e. a CT angiogram in the emergency department, an angiogram followed by another angiogram for a staged procedure in a short period of time. Certainly it does increase the risk. And so here is a commonly used risk score that has been used. And you can see here various points are assigned. So for our particular patient, he's older than 75, so he gets 4 points there. He has diabetes, so he gets 3 points there. His GFR was 47, and so he would get 2 points there. Based on this, his risk is about 14% for contrast nephropathy. But you can see here the risk for dialysis for all of these, except for the highest group, is quite low. But nonetheless, the risk for contrast-induced nephropathy for this gentleman is in the moderate range, at least in my mind, moderate at 14%. So you have a long discussion with the patient. He is willing to accept the risk and wants to proceed with elective PCI of the 2 lesions on Monday. So it's 5:45 in the afternoon, and the patient wants to discuss strategies to prevent contrast-induced nephropathy. And so he had done his research, of course, on Google and wants to know about N-acetylcysteine, i.e. mucomus. And so he wants to know your opinion. So are you going to give it to him or not? So A or B? Internet says you should get it. Let's vote. Yeah, so 100%. Now, interesting enough, the nephrologist, how many of you guys have had nephrologists that are still asking you to use N-acetylcysteine? Yeah, for some reason, it's still very common that they want it used. And I think this, this is interesting. The first paper that came out was regarding CT scan use and N-acetylcysteine. It was a New England Journal paper, but you can see here, if you look at the sample size, quite small, 82 patients, 41 in each arm. And it did show significant results, and because of this, it became quite popular. Even at some point, remember, there was a shortage of N-acetylcysteine. However, as with other things in cardiology, they've been further studied in larger trials. You can see here 2,000 patients, and you can see there's no statistically significant benefit for the use of N-acetylcysteine. And there have been multiple meta-analyses looking at pooled data, and once again, all the data are consistent that there's no benefit. So as you guys all know, it's been like this for a while. The guidelines show class 3, no benefit. All right, so you discussed that you're not using N-acetylcysteine, and patient wants to know, is he going to get prehydrated, and if so, what are you going to use? And so here are your choices: sodium bicarbonate, half normal saline, or normal saline. So let's vote here. Normal saline, the overmajority, good. And so once again, here are multiple studies of the use of sodium bicarbonate. And once again, as many of you guys remember, when this first came out, I think it was a JAMA article, it was quite popular to use it. And once again, I think the study was ran by nephrologists, from what I recall, from the University of North Carolina. But you can see here, if you look at the meta-analysis, no benefit here. The confidence interval hits 1. And so there was also a lot of issues with the use of sodium bicarbonate, osmolarity, etc. What about half normal saline? So this is a study comparing half normal saline with normal saline. You can see here normal saline seems to be better in reducing contrast nephropathy. So once again, half normal saline out, good old-fashioned normal saline is in. The guidelines are older. This is what they recommend. But as you guys know, there have been several studies looking at some other possible regimens that could be used. And one of them was the Poseidon trial. And I'm curious, how many of you guys use this in some patients in your cath lab? So a few. And you can see here, this is hydration, as I say. It's quite aggressive here. So all patients up front, 3 milligrams per kilogram for an hour. Then they proceed with angiography. And at the time of angiography, you check in EDP. If the EDP is low, you give an additional 5 milligrams per kilogram for 4 hours. And then you can see here, if it's intermediate or high, these are what you give. And so in this study, they're randomized to after angiography, and they get the EDP to be EDP guided for additional hydration, or just a run-of-the-mill standard 1.5 milligrams per kilogram. So one can also a hefty dose for 4 hours post-procedure. And here are their results. So as expected, the ones in the EDP guided group receive a much higher amount of hydration. You can see here about 1.7 liters. And if you look at their outcomes in terms of changes in renal function defined by these various things, both relative and absolute, there was a statistically significant reduction in the more aggressively treated patients. But once again, remember, this is a significant amount of volume, and patients with LV dysfunction were excluded from this trial. All right, so you explain to the patient you're going to use normal saline. Patient checks into the holding room Monday morning. You're contacted at 5:30 a.m. at home and says, the patient's been researching different types of contrast agents and wants to know what you're going to give. And so it wants to know what are you going to plan on giving them. This is assuming you have a choice, that you're not on a contrast shortage and you're hoarding contrast. But if you had a choice, what would you give this patient? Here are your choices. So HiPAC, IsoView, OmniPAC, or VisiPAC, commonly used cath lab agents. So what would you guys use here? How many of you guys were impacted by this contrast shortage out of curiosity? How many of you guys are still impacted by it? I think if some benefits that came from this, we did modify our practice. I'm sure some of you guys have. Also in terms of contrast waste, as well as our injection protocols, we use, the majority of the operators use the auto injector. How many of you guys are using an auto injector rather than a manifold? And so we've reprogrammed our settings on that. Of course, I still drive a manual transmission car. I like the manifold, so, but we've modified our practice. So the majority of people there, I think, chose VisiPAC. So let's talk about this a little bit here. And so there's different types of contrast agents, ionic and non-ionic. I don't think any of us are using ionic agents anymore, so mainly non-ionic. And then if you look at the osmolarity here for the standard low osmolar, and I put that in quotation marks, if you look at the osmolarity, it's still rather high for these low osmolar agents, and then the isoosmolar obviously is closer to 300. As you notice here, the trade-off for this is that these agents are both expensive and they're quite viscous. So for those of you guys that are still using a manifold and are using smaller French catheters, certainly after a case of using some of these isoosmolar agents, your thumb is certainly noticing that it is more difficult to push. Are there data to look at these different various agents describing which ones are better? So I want to look here at the specifically looking at the isoosmolar versus the low osmolar. If you look at this one study where they separated out VisiPAC compared to OmniPAC, which are the most commonly used agents, there may be a benefit in using VisiPAC in these patients. However, if you compare it to other low osmolar agents, there is no significant difference. And I think given the cost of VisiPAC, I think most labs now are using OmniPAC in most cases. And once again, in the contrast shortage, you take what you can get. But certainly there is a significant cost difference in these agents, and there may not be a difference in the terms of reducing contrast nephropathy. So you spend several minutes talking to them. You do use OmniPAC in your lab, and just to make sure the chances of contrast induced nephropathy are low, you do decide to use VisiPAC. And so the cath lab team wants to know what the maximal contrast dose should be for the procedure before you're alerted. Remember, the patient weighs 70 kilograms, has a creatinine of 1.4, and the GFR is around 45. So there's different ways to calculate this. The most commonly used is the maximal contrast dose based on their weight and their serum creatinine, and then 5 times that, 4 to 5 times that is I use 4, but I think the official definition is 5, and the contrast ratio, which is comparing how much is used in reference to this maximal contrast dose. And you can see here, if you use less than, so that i.e. your ratio is less than 1 of 5 times the ratio of their weight to their serum creatinine, the chances of contrast nephropathy are I think exist, but are probably acceptable. But if you go above that, meaning you use 5 times the ratio of their weight to their serum creatinine, the risk goes up significantly. And so I try to use 4 times, although the official definition is 5 times as my limit. Although once the case gets started, sometimes it's hard to stop. But it's important to cognitively be aware of your maximal allowable contrast dose. And once again, it is based off some data here. And so you do the case, you fix the right, then you fix the OM, place some drug-eluting stents, takes you 30 minutes. Contrast low is 100 cc's, your contrast ratio is 0.4, so acceptable, but you'd spent 2 hours talking to the patient. Thank you.